The human heart is an incredible organ, tirelessly working to pump life-sustaining blood through our bodies. But when faced with excessive pressure or volume, it adapts, sometimes at a cost. Chamber enlargement, whether from years of hypertension, valvular disease, or chronic lung conditions, tells a silent story on an ECG. Understanding these changes isn't just about pattern recognition. It's about interpreting the heart's distress signals and acting before it's too late. In this session, we will explore how hypertrophy and dilation reshape the heart's electrical landscape and how to detect them early for timely intervention. Introduction to chamber enlargement. Chamber enlargement occurs when the atria, or ventricles, enlarge in response to pressure or volume overload. Hypertrophy results from pressure overload, leading to thicker walls, while dilation stems from volume overload, causing chamber expansion. Left atrial enlargement is common in mitral valve disease and hypertension, while right atrial enlargement is often seen in pulmonary hypertension and congenital defects. Recognizing these patterns on ECG enables early intervention and better patient outcomes. Understanding work, overload. Cardiac enlargement encompasses both dilation, that is, chamber volume increase, and hypertrophy, that means muscle mass increase. Dilation occurs in volume overload conditions like mitral regurgitation, whereas hypertrophy develops from pressure overload in conditions such as aortic stenosis. While initially compensatory, prolonged overload can lead to cardiac dysfunction and heart failure. Cardiac adaptation. Mechanisms. In response to initial overload, the heart adapts through hypertrophy or dilation to maintain output. The compensatory response varies by chamber. Atria primarily dilate, while ventricles hypertrophy before eventual dilation. Over time, these adaptations may lead to impaired function, arrhythmias, and heart failure if untreated. Basic ECG concepts. In chamber enlargement, ECG changes in chamber enlargement include prolonged depolarization, that is, wider P waves or QRS complexes. Increased voltage, that means taller P or R waves, and axis shifts reflecting dominant electrical forces. These indicators help differentiate normal variations from pathological enlargement, aiding precise diagnosis. Understanding strain pattern. Strain patterns indicate myocardial stress, particularly in severe hypertrophy. Subendocardial ischemia causes characteristic ECG changes. ST segment depression and T-wave inversion in leads overlying the affected ventricle. Their presence suggests advanced hypertrophy and potential ventricular dysfunction. Electrical axis fundamentals. The electrical axis represents the heart's overall depolarization direction. Measured via limb leads, a normal axis ranges from -30 degrees to +90 degrees. Left axis deviation suggests left ventricular hypertrophy or conduction blocks, while right axis deviation indicates right ventricular hypertrophy or right bundle branch block. Extreme deviations often signify severe conduction abnormalities. Axis deviation classifications. Normal axis, that is between -30 degrees to +90 degrees, reflects normal cardiac activity. Left axis deviation, that is between -30 degrees to -90 degrees, suggests left ventricular hypertrophy or conduction disease. Right axis deviation, that is +90 degree to +180 degree, is common in right ventricular hypertrophy and pulmonary disease. Extreme axis deviation, that is between -90 degrees to -180 degrees, indicates severe cardiac pathology. The normal P wave. The P wave represents atrial depolarization, with its initial portion reflecting right atrial activity and terminal portion reflecting left atrial activity. A normal P wave is smooth, less than 0.12 seconds in duration, and less than 2.5 mm in amplitude. The mean P wave vector follows a normal right-to-left atrial depolarization pathway, creating an upright P wave in lead 2. In lead V1, the P wave is typically biphasic, reflecting both atria. Changes in morphology may indicate atrial enlargement or conduction disturbances. Left atrial enlargement. P mitral pattern. A broad, notched P wave in leads 1 and 2 is a hallmark of left atrial enlargement. ECG criteria include P wave duration more than 0.12 seconds, increased terminal negativity in V1, and prolonged interatrial conduction. Left atrial enlargement is commonly seen in mitral stenosis, hypertension, and cardiomyopathies. P terminal force. The P terminal force, measured in lead V1, reflects left atrial activity. It is calculated as the product of negative P wave depth and duration. A value more than 0.03 mm/second suggests left atrial enlargement, aiding in precise diagnosis. Clinical mimics of left atrial enlargement. Conditions like COPD can produce ECG patterns mimicking left atrial enlargement due to diaphragmatic displacement and altered atrial conduction. Differentiating true left atrial enlargement from positional changes requires clinical correlation and imaging studies. Right atrial enlargement is commonly caused by chronic lung diseases or COPD, congenital heart defects, and pulmonary embolism. These conditions increase right atrial pressure, leading to ECG changes such as tall, peaked P waves in inferior leads, that is P pulmonale. Mechanism of P pulmonale in COPD. COPD-induced right atrial enlargement results from chronic hypoxemia, lung hyperinflation, and altered heart positioning. These changes lead to sympathetic stimulation, increased right atrial pressure, and a more vertical heart orientation, affecting ECG patterns. Types of right atrial enlargement patterns. Right atrial enlargement manifests in distinct ECG patterns based on the underlying pathology. P pulmonale, seen in chronic lung diseases. P congenitale is common in congenital heart defects, showing an exaggerated P wave in lead 2. P tricuspidal, associated with tricuspid valve disease, features notched P waves with a prominent first peak. P Ebstein, characteristic of Ebstein's anomaly, produces giant, box-shaped P waves, often larger than the QRS complex. Recognizing these patterns is essential for accurate diagnosis. ECG criteria for right atrial enlargement. Right atrial enlargement alters the P wave, primarily affecting its amplitude, duration, and axis. The P wave remains narrow, but exceeds 2.5 mm in amplitude in leads 2, 3, and AVF. In lead V1, an enlarged initial positive deflection, more than 1.5 mm, suggests right atrial enlargement. The P wave axis shifts rightward, often exceeding plus 75 degrees. Unlike left atrial enlargement, right atrial enlargement does not prolong the P wave duration. Clinical mimics of right atrial enlargement. Several conditions can mimic right atrial enlargement on ECG. Transient conditions such as acute pulmonary embolism or bronchial asthma may temporarily cause tall P waves without structural enlargement. Cardiovascular factors, including myocardial ischemia, exercise, or tachycardia, may also increase P wave amplitude. Body habitus, particularly in tall, thin individuals, can cause an ECG pattern resembling right atrial enlargement due to heart displacement. Distinguishing true right atrial enlargement from these mimics requires clinical correlation and imaging. Pseudo-P pulmonale pattern. Certain conditions falsely suggest right atrial enlargement on ECG. In pseudo-P pulmonale, the P wave appears peaked due to mitral valve disease or electrolyte imbalances rather than actual right atrial pathology. Differentiation relies on evaluating lead V1, where a concurrent negative P terminal force suggests left atrial enlargement instead. Hypokalemia is another common cause, requiring electrolyte correction rather than cardiac intervention. Biatrial enlargement. Biatrial enlargement occurs when both atria are simultaneously enlarged, typically due to valvular heart disease, cardiomyopathy, or chronic heart failure. ECG findings include features of both left atrial enlargement and right atrial enlargement, such as biphasic P waves in V1, with increased amplitude and prolonged duration. These mixed features indicate significant cardiac pathology requiring further evaluation. ECG criteria for biatrial abnormality. BAE is identified through combined ECG changes. A P wave in V1 with a tall initial positive deflection, more than 1.5 mm, and deep terminal negative deflection, more than 1 mm and more than 0.04 seconds, suggests biatrial enlargement. P-wave morphology is often wide and notched in lead 2, resembling left atrial enlargement, but with increased amplitude, more than 2.5 mm, a feature of right atrial enlargement. Prolonged P-wave duration, more than 0.12 seconds, confirms the diagnosis. Ventricular physiology. Overview. The ventricles play a dominant role in cardiac function. The left ventricle, with its thick muscular wall, pumps oxygenated blood systemically, while the right ventricle delivers blood to the pulmonary circulation. Depolarization begins at the interventricular septum, proceeding from left to right before spreading to both ventricles. Because of its greater mass, the LV usually dominates electrical activity, influencing ECG waveforms. The normal QRS complex. The QRS complex represents ventricular depolarization, normally lasting 0.06 to 0.10 seconds. The mean QRS vector points inferiorly and leftward, producing a predominantly upright QRS in leads 1, 2, and V5, V6. Precordial lead progression follows a pattern. Small R waves in V1, V2, progressively increasing R wave amplitude toward V6. Any disruption in this pattern suggests ventricular hypertrophy or conduction abnormalities. Normal QRS morphology in different leads. QRS morphology varies by lead placement. Right precordial leads, V1, V2, show a small R wave and deep S wave due to left ventricular dominance. Left lateral leads, lead 1, AVL and V6, display small Q waves and tall R waves, reflecting leftward depolarization forces. The transitional zone, V3, V4, marks the shift where R and S waves are approximately equal. Any shift in this pattern can indicate ventricular enlargement or conduction disturbances. Ventricular activation. Time. Intrinsicoid deflection measures ventricular activation time, recorded from the QRS onset to the peak of the R wave. In right ventricular activation, deflection is rapid, 0.02 seconds, best seen in V1. In left ventricular activation, it takes longer, 0.04 seconds, seen in V6. A prolonged deflection suggests hypertrophy or conduction delays. Left ventricular enlargement. Causes. LV enlargement results from volume overload, pressure overload, or neurohumoral factors. Volume overload, seen in mitral or aortic regurgitation, leads to LV dilation. Pressure overload, as in hypertension or aortic stenosis, causes LV hypertrophy. Neurohumoral factors such as aging, diabetes, and cardiomyopathy contribute to chronic remodeling. ECG characteristics of left ventricular enlargement. ECG changes in left ventricular enlargement include increased QRS amplitude, leftward axis shift, and repolarization abnormalities. Depolarization changes manifest as high-voltage R waves in V5, V6. Vector shifts cause left axis deviation. Repolarization abnormalities, seen as STT changes in lateral leads, indicate strain due to subendocardial ischemia. Diagnostic criteria for left ventricular enlargement. Left ventricular enlargement is diagnosed using multiple ECG criteria. The Cornell criteria, that is, R wave in AVL more than 11 mm. Sokolow-Lyon criteria, that is, S in V1 plus R in V5 or V6 is more than 35 mm. Framingham criteria and Romhilt-Estes point system improve diagnostic accuracy. A combination of criteria increases specificity. Age and left ventricular hypertrophy. ECG criteria for LVH vary with age. In young adults, high QRS voltage is common due to thin chest walls, often mimicking LVH. Limb lead criteria such as R in AVL more than 13 mm are more reliable in this population. QRS duration, while slightly prolonged in hypertrophy, rarely exceeds 0.10 seconds unless conduction abnormalities coexist. Improving diagnostic accuracy for LVH. ECG diagnosis of LVH is enhanced by combining voltage criteria, strain patterns, and additional clues. Voltage criteria alone have limited specificity but improve when accompanied by ST depression and T-wave inversion strain pattern. Other clues, such as left atrial enlargement and delayed ventricular activation, increase diagnostic confidence. Systolic versus diastolic overload. Left ventricular overload can be classified into systolic or pressure and diastolic or volume overload. Systolic overload, as seen in aortic stenosis or hypertension, presents with ST depression and T-wave inversion strain pattern in left precordial leads. Diastolic overload, typical in aortic or mitral regurgitation, causes tall R waves with upright, pointed T waves without significant ST changes. Recognizing these patterns helps differentiate underlying pathologies. Clinical mimics of LVH. Certain non-pathological conditions can mimic LVH. Young age, male gender, and Black ethnicity are associated with naturally higher QRS voltages. Body habitus influences ECG interpretation. Thin individuals often have exaggerated voltages, while obesity can attenuate QRS amplitude. High cardiac output states, as like anemia, thyrotoxicosis, also produce LVH-like changes without true hypertrophy. Differentiating these mimics prevents misdiagnosis. Right ventricular enlargement. Overview. Right ventricular enlargement occurs when the right ventricle is subjected to chronic pressure or volume overload. Normally, the left ventricle dominates the heart's electrical activity due to its greater muscle mass, but with RVE, rightward electrical forces become more prominent. Common causes include pulmonary hypertension, congenital heart disease, and chronic lung disease or COPD. As the right ventricle enlarges, characteristic ECG changes emerge, providing valuable diagnostic insights. Progression of RV enlargement on ECG. ECG manifestations of right ventricular enlargement progress with severity. Early changes may be subtle, as the left ventricle still dominates electrical activity. In moderate enlargement, right ventricular forces become more evident, leading to mild right axis deviation. In severe enlargement, the right ventricle dominates electrical activity, producing significant rightward axis deviation, increased R wave amplitude in V1, and deep S waves in V6. ECG characteristics of RV enlargement. Key ECG features of RVE include right axis deviation, that is QRS axis more than plus 100 degree, tall R waves in V1, and deep S waves in V6. In lead 2, the QRS complex may appear more negative due to the rightward shift of the electrical vector. The precordial leads also exhibit reduced S wave depth in V1-V2, reflecting increased right ventricular forces. R wave progression in RVH. In a normal ECG, the R wave gradually increases in amplitude from V1 to V6, while the S wave decreases. In right ventricular enlargement, this pattern is disrupted, with an increased R wave in V1, more than 7 mm, progressive R wave reduction toward V6, and deep persistent S waves in lateral leads. This reversal of normal R wave progression is a hallmark of right ventricular hypertrophy. Additional ECG signs of RVH. Further ECG indicators of RVH include delayed intrinsicoid deflection in V1 to V2, more than 0.035 seconds. Reflecting delayed right ventricular activation. A small QR pattern in V1, where an initial Q wave is followed by a tall R wave, suggests severe RVH. STT wave changes, including strain patterns, ICC ST depression, and T wave inversion in lead V1 and V2, lead 2, 3, and AVF, indicate myocardial stress due to chronic overload. Summary of RVH diagnostic criteria. The most critical criteria for diagnosing RVH include right axis deviation, more than plus 100 degree, an RS ratio greater than 1 in V1, and an S wave greater than R wave in V6. These findings strongly suggest right ventricular dominance and should prompt further evaluation for underlying cardiopulmonary disease. Now we are going to discuss some clinical cases on this topic. Case 1. Identifying left atrial enlargement. A 62-year-old patient with rheumatic heart disease presents with exertional dyspnea. ECG reveals a P-wave duration of 0.14 seconds and a significantly negative P-terminal force in V1. These findings confirm left atrial enlargement, likely secondary to mitral valve disease. Clinical correlation with echocardiography is necessary to assess the severity of left atrial enlargement and guide management. Case 2. Identifying right atrial enlargement. A 55-year-old patient with severe COPD complains of worsening breathlessness. ECG shows tall peaked P waves, that is 3.5 mm, in leads 2, 3, and AVF, with a prominent initial positive deflection in V1. Confirm right atrial enlargement, secondary to pulmonary hypertension from COPD. The findings align with the clinical picture of cor pulmonale. A 70-year-old patient with mitral and tricuspid valve disease presents with heart failure symptoms. ECG shows tall, wide, notched P waves in lead 2, more than 0.12 seconds and more than 3 mm amplitude. These findings confirm biatrial enlargement, reflecting significant atrial overload from combined valvular pathology. Case 4. Identifying left ventricular hypertrophy. A 58-year-old hypertensive patient presents for evaluation. ECG reveals an R wave in AVL greater than 15 mm, an S wave in V3 greater than 25 mm, and an R wave in V5 greater than 30 mm, with ST depression and T wave inversion in lateral leads. These findings meet multiple LVH criteria, as like Cornell-Sokolow-Lyon, with a strain pattern indicating severe hypertrophy and subendocardial ischemia. Echocardiography is needed to assess left ventricular mass and function. Case 5. Identifying right ventricular hypertrophy. A 42-year-old patient with congenital pulmonary stenosis complains of increasing fatigue. ECG shows right axis deviation plus 110 degree, an R wave in V1 greater than 10 mm, an RS ratio greater than 1, and deep S waves in V6. T wave inversion in V1 to V3 indicates right ventricular strain, confirming right ventricular hypertrophy or RVH due to chronic pressure overload. Further assessment with echocardiography is essential. Miscellaneous cases. Identifying clinical mimics. Athlete's heart. A 25-year-old swimmer's ECG meets LVH voltage criteria, but lacks strain patterns, confirming physiological adaptation rather than pathology. Body habitus. Effect. A thin patient exhibits exaggerated QRS voltages, mimicking LVH, due to reduced chest wall attenuation rather than true hypertrophy. COPD effect. A 65-year-old with severe COPD presents with a prominent negative P-terminal force in V1, mimicking left atrial enlargement due to lung hyperinflation, altering cardiac position rather than true chamber enlargement. ECG remains a powerful tool for detecting cardiac chamber enlargement, providing critical clues for early diagnosis and management. Recognizing atrial and ventricular hypertrophy patterns allows timely intervention, preventing complications such as heart failure and arrhythmias. I assure, future discussions will be more interesting and explore deeper complexities in cardiac electrophysiology. Stay tuned for more insights into ECG interpretation and clinical cardiology. Thank you.